Thank you very much, and whosoever are listening anyway, OPL and all those things which are popular with people, they should really not be combined with any other session. That will be my advice, and I'll write to them. And mine is you must have read it that this surgery I started or innovated in 2012. And it was published in an index journal, though IGO did not accept it that time. But I think now lots of people tell me that they do it. So it's a autoconjunctile graft for pterygium, and it has definitely reduced in a large way the recurrence of the pterygium. So once you have it's a conjunctival limbal graft, that is limbal cells, which kind of a stem cells or the original cells. So pterygium is a degenerative condition. In fact, I need not to go to details of there are, everything is known about that pterygium surgery does improve the curvature, the refractive error, the vision, everything. So I don't need not to go to that. I will just show you the film really. And it is a very prevalent conditions, and I keep on telling that in Thailand I have seen that virtually everyone has got a pterygium in the nasal and temporal. And they have the large camps for pterygium surgery, and they just keep on cutting, nurses keep on cutting the pterygium and throwing it like a chicken neck. But the chicken is murdered like this. So they have that much pterygium. But we also have in North India quite a bit. It is it's still not that much in South. But at least in Rajasthan, Delhi, and Haryana and Punjab, this is quite still a problem. And pathogenesis, again, I would not waste my treatment was done with mitomycin, and the conjunctival autograft has changed it, and a lot of people doing it, and then but you're using the either glue or sutures. So this surgery which I started, and lots of people do follow it, they feel difficulty, but I think if it is properly done with the patience and giving time of few minutes, this will hold. The conjunctival graft without sutures, without glue, will hold. So I will just show you the surgery, in fact. So basically it is a conjunctiva, pterygium is cut away from the area, and then you bring the graft from the superior limbus to where the graft was to prepare, where graft is to put, and length and width, the graft you take 2 millimeter more than the area. The area is suppose 5-7, then you must have the 7-9 kind of the graft, because the shrinkage of the graft take that into account, that you take 2 millimeter more, the donor area. I hope this works. So this is the surgery, and I think nothing to comment about it. You can see and understand it. It is of course, a grade 1 pterygium beginning only, but it is, in fact, pterygium, longer it goes into the cornea, it leaves the marks and leaves it for a long time. So here we are separating the conjunctiva, the pterygium, and I use the crescent knife to separate it, and then go up and down, see that even the smallest margin of the pterygium must be separated. Though it was looking very small, but see, when I have cut through, then you will find a lot of bare area. So a lot of vertical and a lot of horizontal bare area. Other thing about pterygium is that subconjunctival tissue is the pathogenic, kind of it is pathological, it's not normal. So once you have to excise the subconjunctival tissue also from this conjunctival area where the pterygium was. The pterygium cover, you can preserve a lot of conjunctiva, but the conjunctiva which was really involved in the pterygium formation should be excised so that you have a real fresh conjunctiva as a graft. See, this is separation of the subconjunctival tissue. So I am holding the conjunctiva with a toothless forceps and then separate it from the conjunctiva. And you excise the subconjunctival tissue, which is supposed to be pathological. This is, if you do the histology of this one, it is not a healthy part of the conjunctiva or subconjunctival tissue. So it is a subconjunctival tissue, and you can see now that graph, the area, the bare area will much more than was seen when we started running the video, that the pterygium looked so small. See now, so measure it vertical length and measure its horizontal length, and then inject the subconjunctival jarlocaine, maybe 1%, 2% with adaline, so that minimum bleeding, and make it so thin that conjunctiva, virtually epithelium is lifted up, that not the full thickness conjunctiva. So thinner the graft, better the result. So you have to, so this is the area I have inflated with a, so you can do it under the local also, topical also, but I will prefer that since patient cooperation is required, so retrobulbar or peribulbar injection is good. So patient cooperation is not that much required. So the eye is stable, and then you make a mark, and then start separating the graft area horizontally and vertically, and it should be larger than the bare area which you have measured. And here also that advice is that have the thinnest possible conjunctiva, because we generally don't put suture here. This heals itself. The area from which we have taken this graft, it heals within few days, and you will see next day also many times. Lately I am putting one suture also, limbus and this conjunctiva, and then it virtually fills up very fast. But since we are making it sutureless anything, so if you don't put the suture anything, it really doesn't make a difference. Only thing is that this graft should not be very deep or very thick. It has to be very superficial. It has to be virtually very thin conjunctiva. And then you go in the limbus to dissect the limbal area also, because it is presumed that limbus has those so-called stem cells which makes the fresh cornea or fresh conjunctiva. So we will dissect I'm going deeper into the limbal area and even dissecting a bit of deeper limbal and deeper conjunctival tissue, the corneal tissue. So this is again a patient must dissect into the limbus so that you get really limbal cell, and so we call it conjunctivo-limbal graft, not the autoconjunctiva, but it's a conjunctivo-limbal graft, that you must have the limbal cells also, so-called stem cells of this area, conjunctiva and cornea. You have to guard for the surface, that is, which has to go down onto the area where you are grafting it. You can make a mistake, that if you put it upside down, then there will be problem. You virtually have to redo it. So see, just simply put it there where you remove the pterygium, and put it in place gently with a iris repositor or a earbud or anything. Question is, there have been techniques described where they break the vessels to make the hemorrhage there. That hemorrhage means that it will hold the graft. But I have felt that initially I tried that, but once you have blood under the flap, it tends to get lifted up. So not required at all. In fact, nothing is required at all. Conjunctiva, as soon as it gets attached to its sister cell, it starts secreting the fibrin of its own. So it will be just held up like this, and I keep the bandage. Initially I used to do bandage for more than 24 hours, but now 24 hours, like if I did today 11 a.m., then next day 11 a.m., I'll open the bandage, and this will be fine. Everything is absolute intact. So you have to start with something like Moxi LP, loteprednol, and moxifloxacin 3 times a day. So this will hold it And the low tapered knowledge means that no edema, that edema of the graft should not occur. So initial phase is likelihood, so we have to give the steroids, but low dose, not the high dose steroids. So these are so many the studies done by my PG, and she has done really extensive about astigmatism and vision improvement, and so these surgeries are done in time. They give a very good result to the patient. So these are patients like preoperative, postoperative day, 1 week later, left eye, all these are 6 weeks, 12 weeks. So see that 12 weeks you hardly can make out that there was a graft done. It's virtually absolute normal conjunctiva, no trace of pterygium at all. And no opacity also. If you do it really early, that it is just crossed the limbus, then even if it is 2-3 millimeters, you would generally not find a mark, because this limbus cell will repair the corneal tissue also, that area. So generally opacity is left when it's really penetrates deeper than Bowman membrane and it goes towards pupillary area. So this is right eye, and again pre-op, post-op, 1 week, 6 weeks, and 12 weeks again you can see that is the absolute normal conjunctiva. 6 weeks also is a normal conjunctiva. So try it, and it's really right eye, patient 3, right eye, pre-op, second day, and see 1 week later. But here opacity will be left because it has gone quite a bit and it has got quite deep also. So it would leave the opacity. But opacity tend to get thinner over the time. Since we have put this limbal graft, this does help the even repair of this tissue. So in this study, of course, with till 2 years, no recurrence of any kind. And I think this surgery need to be learned by all young people. And believe it that it is possible to do it without glue and without sutures. And glue, of course, has its own drawbacks of like carrying the mad cow disease and HIV and so many other viral things. So no glue is safe as such, and it is it can produce immunogenic reaction also. So I prefer this one, that no glue, no suture. Suture, of course, has if you are in kind of that not very sure, you can give not all sutures so many around. You can give one there, one here, one there. Just 2 or 3 sutures will do, because it just gets caught very soon with the neighboring conjunctiva. So you can do initially with few sutures, maybe 2, one upper, one lower, and third on the nasal side. But after few surgery, you will feel that you can do it without that. So these are the study done by this girl, and so many of them followed for a long time, and they are good. So thank you very much. I think you can do this surgery, all can be done. Thank you very much.
Hello. Thank you so much, sir. Sir, have you tried this in recurrent pterygiums also? Like if the pterygium is
recurrent pterygium also we do, but that is little efforts are more, and you have to be careful that if somebody has done it 3 times or 2 times, be careful that you are not perforating the sclera or limbus or cornea. That is the tricky part about recurrence. If you have got really recurrent, I did just 10 days back. I don't have the photo of that lady. It was done 3 times at Gorakhpur Medical College. 3 times, and this lady has a thick one, in fact, very bad looking, but after this grafting, everything, she's absolutely fine after now, more than a month now. So in recurrent also you do, but recurrent dissection has to be very careful, because there are fibrosis and adhesions, and you can have a perforation. So that should be avoided. It is very well known that residents, if are not supervised in pterygium surgery, you can have the deep cut in the sclera or cornea. If the complication of perforation are reported.
Thank you so much.